All right. The first bill is House File 2414. So is there a motion on, I will move House File 2414 be referred to the General Register. Thank you. Representative Chair Liebling.
Thank you very much, Mr. Chair and members, for hearing this bill. I know you have the bill actually in front of you. It is a pretty large bill, but actually the provisions that are in front of this committee are don't take up that many pages, I should say. I was going to say they're not that large. They are large, but they're not taking up that many pages in the bill. I'd like to give you just a very brief overview, a little context for what the tax provisions are. As you know, we've got the repeal of the sunset on the provider tax, and we also have a health insurance premium tax credit that are before this committee. These provisions are part of the governor's One Care proposal. So, as members probably know, about 155,000 people, Minnesotans, buy their insurance in the individual healthcare market. And for many of these Minnesotans, the ones who do not have, the ones who are above 400% of the federal poverty level, affordability is a really serious issue because premiums are very, very expensive and out-of-pockets are very expensive. And I know that every member has heard from their constituents that insurance is really unaffordable for many, many people in this area. So part of the governor's package is what we would call the affordability provisions. So he's got what is not before this committee is a 20% discount on premiums that comes right off the top for everyone in this area who buys their insurance through MNsure would get a 20% discount off the top. But then there is this provision that is before this committee for a premium tax credit to essentially extend the federal premium tax credit to people above that 400% level so that everyone would be limited in how much they would have to pay for their health insurance premiums to about 9.8% of their income. So this would make buying health insurance more affordable, essentially for everyone who's in that market. I'll stop on that provision. But the other parts of the governor's package, which are not before this committee, but just for context, we have the 20% discount, the state-based premium tax credit, and then we have a couple of benefit packages that are right now more for our public programs, but that create a single pool for dental care and a single pool for prescription drugs. And those two pieces are not before this committee, but just for context, they are part of the governor's One Care proposal. And then finally, the governor has a platinum insurance product that comes online in 2023 that would provide a better health insurance option that would help people be able to buy an insurance product that has lower out-of-pockets and actually covers more of their health care needs. So that's the context. So I've mentioned the health insurance premium tax credit. Of course, one of probably the most important piece that's before the committee today is the repeal of the sunset of the 2% provider tax. And members have probably heard me say this before. I believe that the provider tax, the funding of the Healthcare Access Fund, which is what this tax has helped to fund, the Healthcare Access Fund is one of Minnesota's premier advantages when it comes to health care and health. It not only provides health care for, the estimate is about 200,000 Minnesotans. It supports the health care of over 1 million Minnesotans, 1.2 million approximately, who are on our public programs now. But it also supports health improvement options for every Minnesotan. And I think also very importantly, it provides absolutely critical flexibility for Minnesota to continue improving both the health of our population and the health care that is available to our population. So I view this as absolutely critical to our state. And so with that, I'm going to stop talking and let Commissioner Bowerly say a few words. She can give you more of the details of the proposals that are before this committee. So thank you, Mr. Chair.
Thank you very much, Representative Liebling. And members, there is this sheet right here that kind of has some of the tax items on it, just the few items that we're going. So it's on a 8.5 by 14 sheet of paper. So it's got 2019 session proposal tracking, and then to the very upper right, House File 2414 tax item. So that might give you the numbers and so forth. So it shows that the health insurance premium tax credit would be a cost, is that part, in 20 and 21 of 44.6 million, and for 22 and 23, 257.2 million. And then it's got information on the amount also for the provider tax. So members, if it's all right, I'd actually like to go to maybe all the testifiers before we went to questions and/or amendments. And we'll start, if that'd be okay, we'll do that. Commissioner Bowerly, welcome. Good morning. And
good morning, Mr. Chairman. Thank you. My name is Cynthia Bowerly. I'm the Commissioner of the Minnesota Department of Revenue. I want to thank you, Mr. Chairman, members of the committee, and Chair Liebling for the opportunity to provide some testimony about the bill before you today. The governor and lieutenant governor, when they proposed their budget, was founded on three of the most pressing areas for Minnesotans. One of those was healthcare, of course. And so the provider tax, of course, is critical to that, making sure that Minnesotans have access to high-quality healthcare. There are many pieces that must be put in place in order to provide a comprehensive solution to health and healthcare access across the state of Minnesota. And these key provisions are carried before you in House File 2414, the HHS Omnibus bill. A couple of the main pieces of the governor's plan are maintaining the healthcare access fund with the sunset of the repealing the sunset of the provider tax to ensure continued access to lower cost healthcare for insurance to farmers, small businesses, owners, entrepreneurs. And by maintaining individual insurance market stability through the premium subsidy and the state-based health insurance tax credit. And then finally, the additional care and packages that are a part of the governor's One Care proposal. I will focus my testimony this morning on the tax items with the state-based health insurance tax credit and the provider tax. The Healthcare Access Fund, as I think you know, and was created in 1992 in Minnesota to improve the health of Minnesotans through prevention and by expanding access to health care, contain health care costs, and improve the quality and affordability of health care services for Minnesotans. So it was a very long time ago that this state decided to make these investments in people's health across the state. Access to care is improved through payment and subsidies through insurance, both Minnesota Care and medical assistance, ensuring that people can get to preventative care and take care of their health needs before they can become a crisis or urgent and then wind up in emergency rooms. And through grants and programs that directly support the provider system, especially rural and safety net providers and those providing care to underserved populations. The Minnesota Care program alone provides health care coverage for more than 83,000 Minnesotans across the state who earn too much to qualify for Medicaid, but whose incomes are below the 200% of the federal poverty line, and they don't have access to otherwise to insurance provided by their employer. Access to care for all of those in insurance, for all insurance markets, is supported by statewide prevention and the state's capacity to track and analyze trends in healthcare spending. The provider tax generates about 80% of the revenue for the Healthcare Access Fund and is the reason for its stability and the ability to keep pace with the costs of care and other programs provided by the Healthcare Access Fund. In addition to those two primary programs, Minnesota Care and Medical Assistance, since its inception, the provider tax has funded the Minnesota Department of Health's Office of Rural Health and Primary Care, and policy analysis used by the legislature, researchers, and others through the Health Economics Program. Expanding the quality improvement and prevention efforts, including the statewide Health Improvement Partnership, or SHIP, were significant components of the last time we took a look at the comprehensive healthcare reform in Minnesota, passed with strong bipartisan support in Governor Palente's second term in 2008. SHIP is the only statewide system to offer effort to reduce the top 3 risk factors driving the majority of chronic diseases, which collectively account for about 80% of all healthcare spending. The revenues for the Healthcare Access Fund come from several sources, but primarily from the 2% tax on healthcare providers. We need to repeal the sunset provision in the provider tax to maintain these essential health programs for thousands of Minnesotans. The provider tax is levied from patient services at hospitals, surgical centers, and healthcare providers. It also applies to the gross revenues of wholesale drug distributors, as well as on amounts paid for prescription drugs by entities subject to the legend drug use tax. There are a couple of more technical provisions related to the provider tax in this bill, Mr. Chair and members, that relate to Wayfair changes. You're familiar that the United States Supreme Court decision in Wayfair versus South Dakota ensured that the state could extend its authority to remote sellers. There are a couple of provisions that have the provider tax for wholesale drug distributors and the legend drug distributors that need to be updated to accommodate the changes the Supreme Court announced in the Wayfair decision last year. We want to ensure that there is fairness for remote sellers located outside of the state to collect items on the same items that they would have to pay the tax on if they were selling from a store in Minnesota. Under those technical changes, the taxpayers who have nexus under those provisions now have the obligation to also collect and remit the provider tax. I'd like to take a moment to describe the state-based health insurance tax credit, which is a key element of the individual market stabilization package that is in the governor's program. As Chair Liebling mentioned, one component is a subsidy that is a 20% subsidy program designed to replicate the 20% discount for Minnesota consumers who purchase their own insurance on the exchange. The state-based health insurance tax credit is available for Minnesotans whose annual income is in excess of 400% of the federal poverty guidelines. These individuals do not qualify for the federal assistance when they enroll in qualified health plans through the exchange. These Minnesotans pay full premiums for health insurance coverage. For 2019, 400% of the federal poverty guidelines for an individual was $49,000, and for a family of 4, it was $103,000. These Minnesotans pay full premiums for health insurance coverage when purchased on the exchange. Starting in plan year 2021, state-based health insurance tax credit would be available for households and individuals with an annual income that meets those guidelines, and the credit would ensure that they pay no more than 10% of their income on health insurance premiums. The credit is based on the cost of the benchmark plan in an individual rating area and tied to the federal benchmark affordability percentage, which currently is 9.86%. So just a couple of examples, members. A 61-year-old individual living in St. Cloud with an income of $55,000 who enrolled in a silver plan would have a monthly premium of $693. They would receive a tax credit of $316, reducing their monthly premium to $377. A couple in Anoka with an income of $75,000 who enroll in a bronze plan with a monthly premium of $1,021 would receive a credit of $593, reducing their monthly premium to $428. The state-based credit can be paid in advance when the household enrolls in coverage, and so that can reduce the amount that they are paying directly each month, or they could choose to claim that on their income tax return as a refundable credit. On either case, the department will review as a part of their individual income tax return to make sure that the right amount of the credit was paid to those individuals based on their actual income for that year. We may pay an additional refund, or we may collect additional tax if the payment received was too large or too small. Over 45,000 Minnesotans are expected to qualify for the credit by 2023. This includes over 34,000 Minnesotans already in the individual market and over 13,000 uninsured Minnesotans who would join the individual market as a result of this new opportunity. Thank you, Mr. Chair and members. We appreciate the time to share information about the new tax credit and its benefit to Minnesotans and the vital importance of extending the provider tax to fund essential services for so many Minnesotans. And we thank you, Mr. Chair, for hearing the bill, and we thank Chair Liebling for including so many of the governor's provisions in this bill that is moving forward.
Thank you, Commissioner Bowerly. Questions, members? Chair Davids.
Thank you, Chair Marquardt. Maybe for staff here, I'm a little confused on the credit because normally tax credits are carried in the tax bill, not in any other bill. So my question would be, when do people get the credit and how do they get the credit? I'm a little I'm very concerned that I'm not concerned that if they have more coming that they get that, but if you got to claw back money, that could be a very substantial amount. I'm concerned about that part. But to staff, when do they receive the credit? Who gets the credit? And how do they receive it? Normally, on a credit, you get it on, you file your taxes, there's a tax return, you get the credit. How is this credit paid?
Mr. Klayman?
Mr. Chair, Representative Davids, how the credit would work under this bill is that a taxpayer could elect to either take that as a refund in the manner that you described that would be typical for collecting a refund, or they can apply for an advance credit. If the taxpayer applies for an advance credit, then the amount of the tax credit would be transferred to MNsure, and MNsure would then distribute that to the insurance company that the taxpayer is using.
Well, so
Chair
Mr.
Davis.
Chairman, so what we're doing, we're writing checks to insurance companies through this program. Is that, or Mr. Klayman, or Mr. Chair, is that correct, Mr. Klayman?
Maybe Chair Liebling would like to answer that, or Commissioner.
Well, yeah, thank you, Mr. Chair. I would say that, you know, I mean, people know that this is not, in my world, this would not be the ideal way to go. But in fact, this is very different than what reinsurance is doing. Reinsurance is paying insurance companies directly, and the consumer never, or through MCHA, but regardless, the money is going right to the insurance company. The consumer is not in there, is not seeing it, is not understanding what is being done on their behalf. In this proposal, yeah, there's eventually a settle up with the insurance companies. However, the consumer would see the discount coming to them, and the consumer would see the tax credit on their return, is how I understand it. Maybe Commissioner Bowerly would like to speak to it as
Commissioner
well.
Bowerly, would you like to add to that?
Chair Marquardt and Chair Davids, you're correct. It would be, if the individual chooses to have an advance payment, then it would be applied directly through their enrollment process. And if they choose to have it as a refundable credit, they would apply for that credit on their individual income tax returns. Under either of those scenarios, the department will work with the exchange to ensure we have the correct information, because when you enroll for health insurance, right, it is a year prior to the tax year that we would be accounted for, and we would ensure that the individual or family receives the right amount based on their income for that year and the right amount of credit that they would be entitled to.
Chair David.
Well, thank you, Mr. Chairman. So to Commissioner Bowerly, well, first of all, reinsurance that we have now does not pay money to insurance companies. It's a reinsurance pool that if an insurance company has a shock loss, then they get it, but they're not writing checks to an insurance company. If an insurance company has no shock losses, they get no checks. This myth about money going directly to insurance companies for reinsurance is B as in B, S as in S. Okay, now my question is, who's writing these checks to the insurance companies? And where's the money coming from?
Who wants that? Commissioner Bowerly.
Mr. Chair, Chair Marquardt and Chair Davids, the money is coming from the Healthcare Access Fund to help stabilize the market. It is going through the exchange to the insurance companies that are offering those plans on the exchange and the individuals who are rolling in the exchange.
Chair David.
Thank you, Mr. Chairman. So members, we have government writing checks directly to insurance companies. I thought that was the big thing, why reinsurance was so bad, even though it was outright lies. They were being told about what happens with the reinsurance program, outright lies. No, I can't say lies. The truth is exactly contrary to what has been said. So now we go from a program where an insurance company could get nothing to a program where government is writing checks directly to insurance companies. What am I missing here? Nothing. Thank you, Mr. Chairman.
Representative Pavia.
Thank you, Mr. Chair. A point of clarification, I hear here with regards to this individual market and the premium subsidy in the individual market stabilization plan, about the exchange and the money that's going to be available to individuals. What about a lot of my friends and neighbors who are small business owners, farmers and so forth, who don't want to use the MNsure exchange? They want to use their small town agents, because when they have a question about benefits and so forth, are those folks also going to be eligible for this 20% premium subsidy, or is it forced on folks only, or is it available to folks only if they use the exchange?
Commissioner Bowerly.
Mr. Chair Markert and Representative Fabian, it is available for those who use the exchange.
Representative Fabian.
So to clarify, you're shutting out my friends and neighbors and many people who choose to use their local agent to purchase their insurance there instead of on the exchange. Is that what you're saying?
Chair Markert
Commissioner
and
Bowerly.
Representative Fabian, I think shutting out is a people have the choice to use the exchange. There are benefits that are available on the exchange because that is how we can make sure that we are providing this benefit to them. The subsidy, the premium subsidy of 20% and the tax credit that is available to ensure that your premiums are 10% or less of your income are available on the exchange.
Representative Fabian.
Thank you, Mr. Chair. Yes or no? Are my small town agents and their customers going to be able to get this 20% credit?
Not unless they use the exchange.
Representative
So,
Fabian.
thank you, Mr. Chair, I appreciate that. So you said that using the exchange is the only way that you can make sure that they are doing this. So you don't trust our small town agents and my residents to be honest with government and file some sort of other return or some sort of a claim?
Commissioner Bowerly.
Mr. Chairman and Representative Fabian, that is absolutely not what I said. I have no reason to mistrust anyone who files their taxes. We work with millions of taxpayers every single year.
Representative Fabian.
Thank you, Mr. Chair. So Chair Liebling, why would you eliminate the ability of my small town agents and many agents all around the state from being able to use this program?
Mr. Chair.
Chair Liebling.
Thank you, Mr. Chair and Representative Fabian. My understanding is there are about 1,000 small-town agents who are, in fact, MNsure navigators who are working very well with MNsure. So there may be some who choose not to, but I don't think that this is leaving them out at all. And just to be clear, right now, if you're under 400% of the federal poverty level, but still have enough income that you don't get onto our public programs, and you were buying in the individual market, you don't get the federal tax credit unless you go through MNsure. So that's already in place, and it has to do with how we're able to calculate how much a person should be able to receive. It's simply a matter of practicality. It's not a matter of preferring anybody, but this is how it is now. And so the program here really just expands on that, and it's not dissing anybody. It's simply, this is the mechanism that we have for making sure that we can determine eligibility and make sure that this money goes to who it's supposed to go to.
Representative Fabian.
Thank you, Mr. Chair. Excuse me, I'm sorry. I just find this all very disturbing. I can't imagine why you wouldn't make this available to some people that choose not to use the exchange. I just am really troubled by this. And, I hope that we can make some changes.
Very good. Representative Yoakim.
Thank you, Mr. Chair, and thank you. You described all this pretty well. I'm not on HHS. I don't know if many of us on this committee are, and I haven't had enough coffee this morning, so I just want to clarify so I'm sure I understand. So this is functioning just like the federal credit, where if you don't go through an exchange, you don't get it. Is that accurate?
Representative Liebling.
Thank you, Mr. Chair, and Representative Yoakim. In that respect, it is. Yeah, I think there are some other differences that the commissioner could speak to, but in that respect, yes.
And Mr. Chair?
Representative Yoakim.
And from what I understand too, is that local insurance agents or brokers can choose to be a navigator and be part of the system, so they're not frozen out right now and they wouldn't be under this bill.
Representative Liebling.
Mr. Chair, Representative Joachim, that's my understanding, yes.
And one more quick follow-up, just so I'm getting this right. So currently under reinsurance, any insurance company that had a claim between $50,000 and $250,000 could get a check regardless of who the claimant was, regardless of their income level. It was just kind of this blank check in hopes of, without any parameters on that, they'd actually lower the premiums. Where this system is more, I guess you'd call it a pay-as-you-go. We're only shelling out the money if the individual qualifies for the credit and if they claim the credit. Is that accurate?
Representative Liebling.
Thank you, Mr. Chair, Representative Joachim. I think that's accurate.
I think that's pretty fiscally responsible. Thank you.
Representative Loeffler.
Well, thank you, Mr. Chair, and the information has since come up that yes, brokers qualify. I've met with a broker in my district who's very happy helping people compare their options. The advantage of the Insurance Exchange is it actually gives you comparable apples to apples ability to understand the difference between the programs and the different policies that are available to you. But I do know that some brokers, at least in my area, are finding it a very useful tool and are using it regularly.
Chair Davids.
Well, thank you, Mr. Chair. A couple of things here. Another part of the bill, well, first of all, people are saying, I'm saying, hey, if you continue the sick tax, that's a tax increase. And they say, no, it's not a tax increase. Well, it'd be kind of like, let's say I had a house loan. Let's say I had a 30-year mortgage. I sign the papers, I agree to the 30-year mortgage, I pay it off. My banker comes to me and says, oh, by the way, we want to continue that mortgage on you. Well, that's an increase to me. That's an increase. So let's not say it's not an increase. It is, because it's going away. Governor Dayton signed the bill in 2011 saying this thing goes bye-bye way into the future, into 2019. Well, now 2019's here. And so where I come from, a deal's a deal, and we're breaking that deal. But we're doing that, seem to be doing that quite a bit here lately. So my good friend on the other side of the aisle was mentioning that under reinsurance, there's no checks to reduce premiums. It doesn't have to go reduce premiums. There's not in this either. There's nothing that says premiums need to go down because we're giving money to these funds if you go through the exchange, and a lot of folks don't get it. So there's no criteria now to lower premiums, none. Now, maybe staff could describe to me what happens here with the savior to many people called short-term major medical. What does this bill do with short-term major medical?
That's not a tax.
Mr. Claimant.
Mr. Chair,
Yeah.
Representative Davids, I believe that the only insurance plans that this particular, so the advanced tax credit would cover would be those that are available on the MNsure exchange, so I'm not sure if those would be covered by.
Well, thank you, Mr. Claimant. I
Yeah, Chair
understand
Davids, I
that.
don't know if that's necessarily, we
Well,
might
that's
not
who
know that in the
insurance
tax
premium
realm
tax-
here,
well, it's the
but,
premium tax effect.
oh,
You got to pay premium tax on it. So from what I understand, the short-term major medical issue that pays a premium tax is limited, okay? Now, I'm working with two folks right now. One of them's a big supporter of MNsure and the Affordable Care Act. And they have messed it up so bad that they contacted him last week and says he doesn't have any coverage. And I said, well, you better get some short-term major medical on that to get you to the 1st of January. That's the only thing that's going to save you. It doesn't cover pre-existing conditions, but you have a massive heart attack or stroke or a car accident or something like that. In a car accident, you got your PIP coverage first, but that $20,000 is used up in about 5 minutes. And so it's a very, very valuable policy to get people through to January 1st. Since before all of this, you could buy a health insurance policy any day of the week. Now you can't. You have people that come in, MNsure messed up, the biggest failure of all time, MNsure. You go into MNsure, they mess it up, and I'd like to give you names, but I don't have permission at this time. And so my comment to my client who was big on Obamacare and thing, I said, how are you liking it now? He says, well, not so much. So the short-term major medical, we're going to have to make sure that we don't do anything to mess that up, because that's a very, very valuable thing, basically clean up the messes of MNsure to get people to January 1st of the next year. Very, very valuable to do that. So just to review a couple things, there's no premium checks to reduce premiums on what's going on here. Yeah, it'll reduce premiums, but so does reinsurance. But there's no guarantees that the insurance companies under this plan, under this scheme, are going to do anything either. So a couple things to look at. I'll be following up on the short-term issue. And to say that continuing the sick tax is not a massive regressive tax increase on the poor is just not true. Thank you, Mr. Chairman.
Representative Schumacher.
Thank you, Mr. Chair. And first question for the discussion on this bill. I'm just wondering with this, the proposal that we've been talking about currently here and the fiscal responsibility of being able to limit the people who get reductions in their health insurance based on if they go through the exchange or not. In order to trust the people who are filing these, we're going to have more people processing these. How many FTEs are going to be in this fiscally responsible proposal that is in front of us?
Commissioner Bowerly.
Mr. Chair, Representative Schumacher, if you'll give me one moment, I can take a look at that.
Commissioner?
So, Mr. Chairman and Representative Schumacher, there are, as you would see in the, if you looked at the governor's change page on this item, there is a breakdown of the costs related to the state-based premium tax credit. There are costs for administering this both at MNsure and at the Department of Revenue. We would need to make sure that we have the data about the enrollment information so that we could work with taxpayers when they file for that tax credit on their individual income tax return to make sure that we can get them the right amount of the credit that they're due based on their actual income for that tax year.
Representative Schumacher.
Yeah, I'm sorry, Mr. Chair, and thank you, Commissioner. What was the FTE number for that?
The total FTE number is about 40 as a startup, and then as the program is established, it reduces to about a little over 30.
Very good. Representative Schultz.
Thank you, Mr. Chair. I just want to thank Chair Liebling for bringing forward a really excellent Health and Human Services Omnibus bill. And I just want to address a few comments that were made. One, we do have in the bill a premium discount of 20% that would reduce premiums, and consumers would know that. They would see the reduction immediately when they went to sign up. Second, MNsure is a website where people go and shop and compare plan products. And so I'm really tired of everyone beating up on a website that functions to help people shop for their health insurance. And so I think there are a lot of good options here to reduce premiums and affecting many people who right now get no help at all in reducing their premium. They're paying the full price. They get no tax discount through an employer, and this bill will really help address individuals I'm hearing from in my district that get no premium relief whatsoever. This is going to help many, many, many people in my district and yours as well that will get some premium relief. So thanks again, Chair Liebling, for bringing this forward.
All right.
Mr. Chair.
Representative Fabian.
Thank you, Mr. Chair. I may have been distracted, but I'm wondering, on the 40 FTEs, what's the fiscal note on the 40 FTEs?
Commissioner Bowerly. And I don't know if that's that line 1096 that we're looking at where it says MNsure administration or. Would, Ms. Templin, would you, Ms. Templin may have that information too, so.
Ms. Templin says the answer is yes, and if she says the answer is yes, we all know the answer is
Okay,
yes.
well.
So I'm sorry, I didn't
So
have the
Commis-
spreadsheet in front of me, but your spreadsheet
So-
is carrying that
Commissioner
on.
Bowerly,
Yeah,
so what is the answer to that?
The answer, I believe, is that it is on line 1096 for the MNsure admin and, right on my glasses, 1095 for the Department of Revenue Administration.
Very good. So Representative Fabian, it's off of that sheet again. There's a 1095 line and a 1096 line that refers to DOR administration and MNsure administration.
So Mr. Chair,
Representative
I just
Fabian.
want to be sure I'm clear here, and Ms. Templin can help me. We're looking at 500 and, what would that be? 5,780,000?
Correct, that looks like for 2021, yeah.
Okay. So that, Mr. Chair?
Representative Fabian?
So does the 40 FTEs is covered by the 5,780,000?
Commissioner Bowerly?
So, Mr. Chairman
Commissioner?
and Representative Fabian, so the line 1095 is the Department of Revenue Administration, and the Department of Revenue's administration is about, is 11 FTEs in 22 and 10 FTE in 2023. And then the line 1096, that is the Administer Administration, and that is the 40 FTE that I mentioned, and the 30 in that starts in 2021.
So it's,
Representative Fabian?
thank you, Mr. Chair. So can you add those totals up for me quickly?
The
Math-
FTE totals or the
No,
dollar
the
amount?
dollar amount totals.
So
Fast as I could, but
it looks like the totals for 2021 would be the 5.78 million,
Yep.
and it looks like,
1.7 though.
well, here, we've got,
You don't have to add because there's zeros.
Yeah.
It should be closer to 58.
but they're,
Well, that's what I'm,
If it's 5.8 million. Unless
About-
you're paying them a little.
Commissioner?
it's my understanding it's about 6.3 for 22. For all 4 years, thank you.
Okay, so Commissioner, what was that number for all 4 years?
I believe it's 6.3.
Okay, about 6.3 million for those 4 years.
so,
Representative Fabian?
okay, so these 40 FTEs, are these the ones who are going to be writing checks out to the insurance companies?
Commissioner Bowerly, what will they be doing?
Mr. Chair and Representative Fabian, so these individuals at Mincher will help ensure that individuals are, as they're navigating into the system, understand what their plans are available to them. They will send them, the shopping tool will need to be updated, so the system will need to be updated to ensure that customers will see the actual price they would pay with the addition of the credit. They will provide notice to the consumers confirming the amount of the tax credit that is applied to their selected plan. They will assist consumers with changing income or other eligible criteria during the year, because when you enroll, if you get a raise or you have a change to your income during the year, then your amount for the credit would change. And then they would provide an end-of-the-year file to the Department of Revenue, and that's where the Department of Revenue's role comes in. We will update the tax system and the forms to ensure that people can claim the credit, and then we will work to reconcile that as a part of the tax filing, the existing tax filing system.
Representative Fabian?
Thank you, Mr. Chair. Well, I think we need to keep looking at this because I'm still not clear. I mean, I'm doing a little math, and I come up with numbers between $37,000 a year and $144,000 a year, depending upon which numbers I'm plugging in for the compensation for those employees and I don't know. You know, when you look at, what is it, 1,130 pages of a bill, it's hard for me to get my arms around it. Well, I don't mean that literally, but it's concerning to me that we're going to grow government so that we can write checks out to the insurance companies, which I was told in the previous 2 years was not a good thing to do. So, thank you.
Representative Liebling?
Well, thank you, Mr. Chair, and Mr. Berg just, used his little calculator to give us the real number. So what we're adding here in terms of additional personnel, so if you add the 5,780,000 that is on the Mincher line for 2021, and then you add what's on the 22-23 number for the Department of Revenue, you get 7,697,000, which is the total for the FTEs over the 4-year period. So the number we were working on wasn't quite accurate there.
And that's what I see, about 7.7 million over those 4
Exactly.
years. All right, Representative Schultz.
Thank you, Mr. Chair. I just want to clarify that some of these FTEs, many are going to be manning the call center, so people can get help, assistance, enrolling, and not have to have long wait times on the call to get that assistance. And that means that many of them will be temporary, that they're going to be there to man the enrollment period and then will no longer be needed. So we really need to look at, you can't just divide the FTEs by this total amount, because many of them who man the call center won't be permanent employees.
And Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair. And I just want to make sure everyone understands, that's not just paying for the people, it's also paying for the system update that would be necessary. So I just want to be sure that that's clear. That's the total additional number.
Very good.
So, Mr. Chair.
Representative Schultz, anything else? Representative Fabian.
Thank you, Mr. Chair. So can we get a breakdown on the FTE cost? And then also the system upgrade cost? Because when I just did the numbers here real quick again, the basically 7.7 million divided by 40 FTEs, because we're talking about full-time equivalents, whether they're part-time workers or full-time workers, we're talking about full-time equivalents, and that comes out to a compensation number. And again, as we've said before, I'm a FIAD teacher, not a math teacher. But for me, that's $48,700 a year, and I'm quite sure that the compensation numbers that we have for state employees is much higher than that, but
Yeah, is there a breakdown, either Commissioner Bowerly or Representative Liebling, on the system upgrade versus personnel? Did anyone happen to have that, Commissioner?
Chair Marquardt and Representative Fabian, one thing I would note that we provided you with a 4-year number.
okay.
So that includes both system costs and FTE costs, but there are 40 FTE per year. So I think the math is not just to divide the total 4-year cost with the annual FTE number. A little bit of that is that. I am trying to make sure, before I give you a number, that I understand which of these expenditures are systems.
You know, and we could come back to this after taking more, would that be all right, Representative Fabian?
Thank you, Mr. Chair. Yeah, I'd like actually some more detail on the system upgrades.
Okay.
We've had a few glitches in our systems here in the state of Minnesota, and I'm skeptical.
So let's see if we can get those, and we'll continue on here if we can get these before we're done here. We'll provide that. So Representative O'Neill.
Thank you, Mr. Chair. And to that point, since we're gathering a little bit more information, just wondering on the backside, the program that the counties use has never worked very well, and my counties are incredibly frustrated with that, the METS program on the backside. Wondering if this change is going to do anything to help counties navigate through and actually perform their duties correctly and cut down on some of their burden and their time and their frustrations. Is there any money in there to accommodate the counties on the side they have to use?
Representative Liebling.
Well, thank you, Mr. Chair and Representative O'Neill. There is some other money in the budget to keep working on that, but it's really separate because I think what you're referencing is eligibility for public programs. That's been, so when somebody comes to MNsure and it turns out that, they put in their information, they're eligible for public programs, there's a handoff to counties, and there's been issues there that are better but still not fixed, right? So I think we all understand that. But this is, what we're talking about here is people who are not eligible for public programs. So as I understand it, maybe the commissioner can correct me if I'm wrong, but there's no county piece to this at all, because these are people that are not even eligible now for help with their premiums. We're talking, well, let me correct that. The 20% is for everybody who's buying on the private market, but the state-based premium tax credit is only for people who right now, as Representative Schultz said, get no help. So these are not people who are eligible for public programs.
Mr. Chair.
Representative O'Neill.
Thank you. Thank you, Mr. Chair. So, but the MNsure program, which is what we're talking about, the programming, and you're talking about expanding, and updating the program so we can accommodate this additional change is what the counties use because it's all been lumped together. And they call it METS, I call it a mess. Last I talked to them, they were able to accommodate 3 or 4 changes every few months when there were hundreds of changes needed. And at one point, they couldn't even take someone out of the system that had died. They couldn't add people that were born. They couldn't make any changes. They had to go through 18 different screens to change an address for one person, and then they had to change addresses for every person in the household, which took another 18 screens. It may be the worst system that the state of Minnesota has ever created, but then MNLARS happened. But this actually is worse. I'm wondering, are we doing anything besides fixing little tiny itty bitty problems compared to the massive problem that the counties have to navigate that's the same program?
Representative Liebling.
Thank you, Mr. Chair and Representative O'Neill. Well, it's not the same program, and, it's, MNsure has several different functions, and as I said, the handoff to the counties on public programs is what you're talking about. This is not having to do with any handoff to the counties. The counties have no role in this, as far as I am aware, at all. So, yeah, in the Health and Human Services bill, you're going to find things that pertain to counties, and, there's a lot we do in the Health and Human Services space that involves counties. What we're talking about here does not involve counties, even though yes, it's being carried in the same bill as some of those things. But, and as I understand it too, what is planned in terms of the technology for this is to use a program that's been used in other states, a vendor with a, off the, I don't know if it's completely correct to call it off the shelf, but it's a very well-proven piece of technology. And just because MNsure is the umbrella organization does not mean it's the same technology that's being used. This is a new program, and my understanding is it has nothing at all to do with METS.
Mr. Chair.
Representative O'Neill.
Well, now I'm just really confused because so now you're creating a whole new program that's outside of the initial program that took, I don't even know how many years to try to build, and it wasn't built well. And yet, yes, it was called METS until, that's what the counties call it on their side because they had used their legacy program, which now they wish they could go back to. That was my gosh, it was green screens that we had used back in the 80s. And when they had millennials come in, they're like, what is this? We don't even know what this is. Now they wish they had the green screens back. But in any case, so now you're talking about it's a whole different program, not, I guess I'm really confused. So now you're doing an entirely different program, which obviously will have to be modified. And how long will that take? And when will this actually launch?
Representative Liebling.
Well, Mr. Chair and Representative O'Neill, you're doing a great job of trying to confuse everybody here. This is not about the public programs. Actually, MNsure does a very good job right now of helping people with the premium tax credits. It's already been doing this for quite a long time, where people who apply on the private apply through MNsure, and they're not eligible for public programs, and they're going to get a premium tax credit, and they get that through MNsure, as far as I'm aware, pretty well, because I don't hear any complaints about that piece of it. And that's the piece that is, is being added to. And so that is not METS. And so you can use this opportunity to go through all that stuff about, ancient history. Some of it, it's a totally different topic that I would argue is not really in this committee today. It's a different topic. What's being proposed here is already, part of it is already kind of working through MNsure very well, and it has nothing to do with METS.
Representative O'Neill.
Thank you, Mr. Chair. Well, I'll just wrap it up. I'm not quite sure exactly what we're creating here for doing like another database. And, we've had insane issues with our databases from MNLARS to MNsure, which had been called METS. And I'm not sure exactly what we're talking about now. I have had extensive conversations with my county. I've sat there at the computer and looked at the programming, and I've, maybe it's a totally different program. So with this new program that's apparently not METS and not MNsure, I'm not sure what it is, when is the effective date? When does this actually start? I thought I heard something about 2021 But when does this 20% discount actually become effective, and when can people access it?
Commissioner Bowerly.
Thank you, Mr. Chairman and Representative O'Neill, and I'll try to do my best to answer Representative Fabian's questions about the technology build as I try to explain how this is going to roll out. As we put together the governor's proposal for stabilizing the individual market, and which is carried again, thank you to Chair Liebling, is the first piece of it is a 20% subsidy reduction. So when people go to enroll in their plan this fall, they will see the 20% reduction available then. For next year, for the health insurance that they are purchasing for next calendar year. And then we will roll out the tax credit portion of the plan. And so that will be built into for the following plan year, which is the same as a tax year. And so that will be, so the following fall, so in the fall of 2020, the tax credit would become available. And then in a following year, some of the other elements of the One Care proposal are going into place. And I will assure you that as the administration was developing these plans, one of the reasons we are rolling this out in phases is to ensure that we can get the technology right so that we can deliver for our customers. So Representative Fabian, you had asked about the technology build. It's my understanding that there's a little over $1 million in fiscal year 20 to make the changes to the MNsure, the exchange system, so that it will be able to accommodate the tax credit and the subsidy. And then in 21, another $1 million. So that's about a little over $2 million on technology of that, of the line you see for the MNsure expenditure in the 2021 biennium of 5.7. And then about $3 million is dedicated to those FTEs who are going to complete all of those tasks. I can go through those again if you like, and also help people navigate the system and understand what they are purchasing. And then there's an additional $500,000 for outreach grants. All of these costs that you see, as you will also see, they have zeros as you move forward for the MNsure because they will be covered by MNsure premium withholdings beginning in 2022. So that is the breakdown of some of those more of those costs. We're happy to give you any additional breakdown you would like. I do want all the committee and Mr. Chair to know that as we built this proposal across the administration, there are a number of different agencies involved. We worked hard to make sure that we could have a plan that would deliver the technology. We understand the challenges. There are customers too. And this plan phases in these parts of the program so that we can make sure we get the technology right for our customers.
Representative Loeffler.
Well, thank you, Mr. Chair and members. I think it's important to kind of go back to what is this about? And this is about the people who don't have the benefit of employer-subsidized health insurance. They make too much money to qualify for state-paid programs, and they make too much to qualify for the federal advanced premium tax credit, which this is modeled after. The state advanced premium tax credit is just an add-on for people who earn over 400% of poverty. And these are the people we've been hearing from that have, high deductible plans if they can afford even the premium for that. And it doesn't kick in until they put in the first $15,000, $20,000, $25,000, $30,000 before their insurance company steps up. And so some of them have been dropping it because they just feel like, I'll never be able to pay that bill to even get any benefit out of it. And this is to make health insurance affordable for people who work for employers who aren't able to offer a subsidy or a benefit, but who still want to cover themselves and their family. And it's a lot of small businesses, it's a lot of independent businesses, and their employees. And that's what we're talking about. And I don't see the complication with adding on a state advanced premium tax credit because we've been doing the federal advanced premium tax credit without problem, without any issue. And we did do the 20% rebate under the first year after the exchange was set up, and it worked fine. It's bringing it back so that it's direct accountability. And I think for customers, they're going to love being able to put in their income numbers and see what they're going to get as a reduction in premiums when they're trying to decide what can they as a household afford over the next year. And I don't think any of this is exotic. I think it's all been proven within the state of Minnesota. And I think it's the right thing to do to step up for families and households right now that aren't finding anything that works for them in the private market. And this will take some of that edge off and make it a predictable item in their budget.
Chair Davids.
Well, thank you very much. Just regarding the last comments, the first 25% rebate was not run through MNsure, it was run through the insurance companies, and it was an extremely successful, well-run, efficient program.
Commissioner Bowerly, thank you so much.
Thank you.
All right, continuing on for testimony, we have Gary Wordish and then Emily Myatt. We will try to limit testifiers to about 2 minutes if possible. So, welcome.
Well, yeah, thank you. Good afternoon, Chairman and the committee members. I'm Gary Wordish. I'm president of Minnesota Farmers Union, a grassroots organization representing farmers in rural communities around the state. This bill, we've held what we call rural voices discussions around the state the last couple of years, and we started a new series of them again now. And the number one issue we hear as we go around the state is the high cost of health care. And Representative just made comment about that. The people are paying as high as $45,000 a year in health care costs. And with the low profits on the farm economy right now, that's just unsustainable. So I guess I'm here today this bill includes a number of provisions that are important to our farmers, including the One Care buy-in proposal, which we are eager to see passed into law. But today I want to speak in support of the one critical provision that we need to take action on this year is repealing the sunset of the provider tax. Farmers are small business owners. As you're well aware, it is well publicized that, the university extension, the median farm income was $26,000 this last year, which is the lowest in, I believe, 23 years, and the bottom 20% actually lost $72,000. So unfortunately, in this tough economy, a lot of the farmers are qualifying for public programs. The provider tax is a key funding source for these programs and others that provide a safety net for farmers, small business owners across the state. It's a time-tested, reliable source of funding. If you remember, this program was started in '92, if I have my years right, under a bipartisan legislature, just like we have today, and a Republican governor, Arnie Carlson. It's worked very well. When that passed, I remember I had a local neighbors of ours, young dairy farmers, that I think at that time they had 3 small children. And after that got passed in the law, they, visiting with them, they said, now we can have some health care. Now we can afford to buy health care. I had a member just in this last year out in western Minnesota made the comment that they were able to come back and start their farm, kind of gradually work into their father's operation. And their access to be able to buy into the MNcare program allowed them to come back to the farm. Without that, they said they would not have been able to come back to the farm. This is a time-tested program. It's worked well. As I stated earlier, it can be done. It was started under bipartisan legislature and under a Republican governor, and very similar to what we have today. So as I travel around the state and talk to members, people are just why can't we get together and figure this out instead of just arguing about it and playing politics with our health care. And I'm in front of a political body today, so I maybe shouldn't have said that, but that's what I'm hearing. People are frustrated. I heard some argument back and forth during this committee, which is fine, but let's sit down and get it together. So now this will help keep farmers on the farm. So it's another option for them. Thank you, Chairman.
Thank you very much. We have Emily Myatt and Mary Krinke is on deck.
Mr. Chair and members of the committee, my name is Emily Myatt, and I'm the Government Relations Director for the American Cancer Society Cancer Action Network, the nonprofit, nonpartisan advocacy affiliate of the American Cancer Society. I'm here today in support of the provision to repeal the sunset of the provider tax. Over 30,000 Minnesotans will be diagnosed with cancer this year, many of whom are receiving healthcare coverage through Minnesota's health insurance safety net programs, which are funded in part by the provider tax. The healthcare provider tax is a time-tested, reliable way to fund these essential healthcare services and enable critical investments in the state and well-being of Minnesota's communities. Programs funded by the Healthcare Access Fund, like Minnesota Care and Medical Assistance, mean more Minnesotans have access to preventative care, resulting in increased early detection of cancers, better outcomes, and improved survival rates for patients and survivors. Cancer patients who are uninsured when diagnosed with cancer are 60% more likely to die than patients who have access to health insurance coverage. Preserving access to health insurance saves lives. We also support the other programs out of the Healthcare Access Fund that increase access to care and help create healthier communities. For example, the statewide Health Improvement Partnership has led to community grants to help prevent chronic diseases like cancer. Letting the provider tax sunset would be catastrophic to the financial health of Minnesota and would jeopardize access to healthcare for thousands of vulnerable Minnesotans and threaten prevention programs needed to curb rising healthcare costs. Too many depend on the programs for the legislature to experiment with funding options or to eliminate the Healthcare Access Fund altogether. With no reliable alternatives being presented, the continuation of the provider tax in Minnesota is the right decision for our citizens and our communities. I believe in your packets is a joint letter from the American Cancer Society Cancer Action Network and the American Heart Association in support of the continuation of the provider tax. Thank you.
Thank you very much. Now up, Mary Krinke. Kate Lynch is on deck. Good afternoon.
Good afternoon. Mr. Chairman and members of the committee, for the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. The Hospital Association supports the repeal of the sunset on the provider tax as contained in the Omnibus Health and Human Services Bill. Over the last 2 decades, our members have really had somewhat of a conversion on the provider tax issue, and we've come to appreciate the many good things that have been accomplished because of the Minnesota Care provider tax. Primarily and most importantly, that is coverage for low-income Minnesotans, either on our Minnesota Care program or in our medical assistance program. The question that I get asked the most often is how will this impact our rural hospitals? And I'd like to just share with you 3 quick points. The provider tax is not applied to any Medicare services. So for most of our rural hospitals, the Medicare population may represent as much as 50 to 60% of their patients, and there is no provider tax on any Medicare service. Number 2, the federal government, CMS, has acknowledged the provider tax as an allowable cost on the critical access hospitals cost reports. We have 77 critical access hospitals in Minnesota, and the provider tax has been acknowledged as being an allowable cost built into their base so that they can get that money back from Medicare. And the third point that I'd like to leave with the committee is that for most rural hospitals, they have pretty small volumes of patients, and any uptick in the uninsured rate really does impact our rural hospitals because they have no economies of scale. So I just would like to leave the committee with a little bit of numbers because this is the tax committee. And the provider tax is in place for the first 6 months of the biennium under current law, but it would go away for the last 18 months of the biennium. That represents $970 million. If any portion of that is used in our medical assistance program, that money leverages a federal matching dollar. So I just can't imagine what our Health and Human Services budget would look like without that money. It is highly unlikely that our commitment to the sick, the elderly, or the disabled would be able to be maintained without the provider tax. Thank you, Mr. Chairman.
Representative Lesligard.
Thank you, Mr. Chair. Rural Minnesota, where I'm from, if I could ask you a question, does this help or hurt the provider tax?
Ms. Krinke?
Mr. Chairman and Representative, the provider tax absolutely helps rural Minnesota. It enables us to keep coverage in our Medicaid and Minnesota Care program. And as I mentioned, any amount of uptick in our uninsured rate really hurts a small hospital because there's no economies of scale. We just really have to maintain the coverage for folks.
Well, thank you.
Thank you very much. Other questions? Thank you very much. Kate Lynch and then Dave Renner.
Good afternoon, Chair Marquardt and members of the committee. My name is Kate Lynch. I live in Roseville. For the past 30 years, I've worked in a Twin Cities clinic all of that time as an LPN in the pediatric department. I'm a member of SEIU Healthcare Minnesota and have been elected to our executive board. Our union represents 35,000 healthcare workers in hospitals, clinics, nursing homes, and self-directed home care. We support House File 2414 because much of the care that we provide depends on the $700 million a year generated by the provider tax. If I had one word to describe our healthcare system now, that word would be fragile. The provider tax is an essential pillar, and it would be incredibly dangerous to take it away. SEIU members all over the state know that our healthcare system depends on the provider tax. Hospital workers in small rural hospitals know that a large share of their patients base rely on medical assistance in Minnesota care. Excuse me. Nursing home and home care workers know that if you get rid of the provider tax, there would not be enough general fund dollars to solve the workforce shortages that they face. Some of you may think that this is an opportunity to eliminate wasteful spending on the system, but every day, healthcare workers like me that see nothing is more wasteful than denying care because patients don't have insurance. This is always especially heartbreaking when you work with children. I remember a family with an asthmatic child who was being treated properly at our clinic. The family lost their insurance, and instead of low-cost regular treatments that were keeping him stable, they were forced into getting far more expensive and less accurate treatments in the emergency room. I can't imagine the stress of waiting for your child's breathing to get so bad that the emergency room will have no choice but to treat them. In this case, everyone lost. The family racked up a small fortune of medical debts they could never pay. The healthcare system had to devote extra resources to solve a crisis that could have been prevented, and all of us had to pay a little extra to cover the costs. Worst of all, small children have to suffer through terrifying attacks that left them unable to breathe. Nothing is more wasteful than letting a treatable illness destroy a patient. There's no better investment than preventing people from getting sick and treating a disease before it gets worse and damages a person forever. We have the tools and resources to give Minnesotans the care they need to live decent lives. The provider tax is one of those tools. As a tax, it has performed reliably for 3 decades through every kind of economy. Please don't let it sunset, and please let healthcare workers keep giving the care that people need. Thank you.
Dave Renner is now up, and then Kenza Haj Musa is on deck. Welcome.
Mr. Chair and members, my name is Dave Renner, here today representing the 10,000 physician and medical student members of the Minnesota Medical Association. And just to make it clear, the MMA does oppose the repeal of the sunset of the provider tax. This sunset was agreed to in a bipartisan manner with Republican legislature and Governor Mark Dayton back in 2011, and it is scheduled to end at the end of this year. We support the sunset, and we encourage you to honor the commitment from 2011. The MMA, however, does support the goals of Representative Liebling and many of those who are hearing to ensure that we have a critical health funding for our critical health care access and safety net programs. To let the provider tax sunset without identifying ongoing funds would be irresponsible. We encourage you to think creatively on identifying ongoing funding, and we ask as you move forward, you consider an updated, modernized finance mechanism other than the provider tax. The MMA believes that there is a way forward to preserve coverage and to ease the cost and burden of tax compliance for healthcare providers and provide stable ongoing sources. The MMA has been working over the last year with consultants and has developed an alternative which is referred to as the claims expenditure assessment, and this is included in Representative Morrison's House File 2789. The claims expenditure assessment moves the collecting and the paying of the tax off of providers upstream to health plans and third-party administrators. The advantages of this assessment is that it is still broad-based as the provider tax, but it's only assessed on paid claims. So patients who are paying out of pocket are not taxed. Patients who are paying for services that are not covered by insurance are not taxed. It also removes the administrative burden of collection and payment and audits from small providers like medical clinics, dentists, chiropractors, and psychologists. Well, while there are many states that use some form of provider taxes, Minnesota is the only state to levy such a tax on outpatient providers. Where this has been used in other states, courts have found that this is not preempted by ERISA, so So this can be assessed to both commercial insurance and self-insured market. Because it is only paid on paid claims, it is less of a sick tax. And by moving the collection and the payment of the tax from providers to payers, the number of entities paying the tax is reduced from approximately 8,000 currently who pay the provider tax to potentially less than 100 payers and third-party administrators. Mr. Chair, it is critical that we continue to provide ongoing funding dedicated to our healthcare access programs. We believe the claims expenditure assessment is an alternative to the provider tax that should be seriously considered as you work to pass the final Health and Human Services budget. Thank you very much.
Thank you. Kenza Haja Musa, and then we have Dominic McQuarrie is on deck. Welcome.
Thank you. Mr. Chair and members of the committee, my name is Kenza Haj Musa. I'm here today on behalf of Take Action Minnesota. We're a grassroots organization. We strongly support this bill and are here to speak to two tax provisions in it. First, we believe our government is responsible for making health care work for everyone. We support the continuation of the health care provider tax, along with many others testifying today, and the nearly 150 organizations who signed on to a letter of support to support the tax. Second, we strongly support the state-based tax credits proposed in this bill that address a problem with the Affordable Care Act. Federal advanced premium tax credits give protection against high premiums to Minnesotans with incomes between 200% and 400% of the federal poverty level, but then the credits drop off. For Minnesotans with incomes just above that line, the state-based tax credits give them a premium affordability standard for the first time. Healthcare affordability is about much more than just premiums, which is why we support many other non-tax provisions in this bill, especially the One Care Platinum buy-in, to make sure that health insurance really covers people's needs. But to the extent that Minnesotans are stuck in the individual private health insurance market, those above 400% of the federal poverty level also need the security of knowing that if the benchmark premium rises above 10% of their income, they'll qualify for assistance. State-based tax credits are a responsible solution as we work toward larger healthcare reforms. I also just want to say my family owned a small business for 30 years, and by the end, we're paying $30,000 a year for health care that they couldn't even afford to use, so it would help a lot of people. Thank you.
Thank you. Dominic McQuarrie, and then Melissa Heising.
Hello, thank you, Mr. Chair and members. My name is Dominic McQuarrie. I'm Public Policy Manager at the Amherst H. Wilder Foundation and serve as co-convener of the This Is Medicaid Coalition, a broad coalition of more than 50 organizations that works to protect the healthcare of Minnesotans who receive it through Medicaid. So along with the 150 other Minnesota-based organizations that are on a letter, we support the full restoration of the healthcare provider tax that's within House File 2414. It's the piece of this large and complex bill that unites nearly every Health and Human Service watcher this session. Minnesota has long led the nation in providing affordable health care to our families, neighbors, and communities. It's the reason that we're often at the top of rankings like the healthiest state and highest in labor force participation. We invest in our people and we see returns. Still, our healthcare system is imperfect. We need to build our mental health system, invest in services to keep people with disabilities in community, ensure our seniors have safe care in their final chapters of their lives. And Minnesota's communities, rural, metro, and everything in between can only thrive when people get the health care that they need. It's a key linchpin in our healthcare system, and almost every state's healthcare system has a provider tax. And as opposed to certain other proposals this session, this is the only one that's time-tested, court-tested, and a reliable revenue source to raise the amount of revenue that we need to cover our healthcare needs. We often forget in these debates about healthcare and taxes that, like it or not, our fates are intertwined with those of our neighbors and fellow Minnesotans. This debate is about each of us and the people that we love. Across the street in the Senate, there's talk about solving this issue with the sunset by cutting dental and vision coverage for potentially hundreds of thousands of MA and Minnesota Care enrollees. While these glasses are very stylish, they're not just for show. I do actually have very bad eyes, and there's no way I would have been able to drive in here today or do my job every day if I didn't have access to the vision coverage that I need. And I know that's true of a lot of people who are doing their current jobs, let alone those who are losing work and need to retrain for new skills looking at screens all day. And that's just the proposal that we have today. As the Healthcare Access Fund is drained, we don't know what will be on the chopping block next. What we do know is we want Minnesotans to have access to the care that they need when they need it. Rolling back the clock on the provider tax and letting it expire will take us back to a time when more Minnesotans were subject to the real tax on the sick, the tax of being uninsured, sick, and out of options. So on this miserable, miserable day, we support the effort to keep the sun shining bright on Minnesota's healthcare. Thank you.
Thank you. Melissa Heising. Good afternoon.
Good afternoon, Mr. Chair and members of the committee. My name is Melissa Heising. I'm Legislative Director for Minnesota AFL-CIO, a labor federation made up of more than 1,000 affiliate unions, representing more than 300,000 working people across the state. Repealing the sunset of the provider tax is one of our top 5 legislative priorities this year. The provider tax funds essential health care services for over 1 million Minnesotans and enables critical investments in the health and well-being of Minnesota's communities. Allowing the healthcare provider tax to expire would create an annual revenue shortfall of $680 million. This loss of funding will jeopardize healthcare access for thousands of low-income Minnesotans, threaten the stability of healthcare, and negatively impact the state budget. Thank you.
Thank you very much. Is there anyone else in the audience who would like to testify on House File 2414? See none. Representative Schumacher.
Thank you, Mr. Chair. And there's a lot of different points that we could talk about with this bill, but I just wanted to focus a little bit more on the healthcare access, or the provider tax that we have in front of us today. The long and short is that this is a regressive tax. Our own tax incident studies tell us that. You can look at a benefit incident study and show that the people who are at the lowest, the bottom rungs, are getting a benefit from it and therefore would make it less regressive. But if you aren't one who qualifies for that, if you're in the middle, making a little bit more than what it takes to get a benefit, but less than, well, anyone who's making more than you, it is still a regressive tax. And so for that reason alone, I would vote no with this, because it's really affecting the people who are stuck in the middle. Secondly, we have seen in the last 20 years that the growth in the healthcare access fund from the provider tax is 3 times that of what we've received in the general fund in that same period of time. And so really it's no wonder that over the lifespan of the healthcare access fund, that almost half the time that the healthcare access fund has been available, that we've been using the funds for things other than Minnesota Care, including expanding Medicaid. And finally, once again, we are making ourselves an island with our approach on this in our tax policy. No other state has a provider tax that's created in such a way to do such a thing. Other states have what they refer to as a provider tax, but none do it the way we do. And so, members, I would just ask that we vote no on this bill today, because this regressive provider tax contributes to and benefits from the high cost of health care. Thank you.
Thank you. Representative Loeffler.
Well, thank you, Mr. Chair. And part of the reason that Minnesota Care was created 26 years ago was because we realized that when you have a lot of uninsured people, it increases the costs of everyone with insurance, because the uninsured still get sick. And they, under federal law and good ethics in our society, no one is turned away when they're sick. Every hospital will accept you, whether you have insurance or not. That is their moral and legal obligation. And what happens when you have a lot of uninsured people, or people who can only pay 5 or 10% over a 10-year premium payment plan back to the hospital, is that all that care cost shifts into the pricing of the hospital to the insurance companies for all the rest of us. And it's been well researched and documented that the costs of the uninsured end up on the insurance rates of everyone else. And by passing Minnesota Care, financed by the premium tax and the provider tax credit, Minnesota reduced its uninsurance rate. We compete oftentimes, we're usually number 2 in terms of the amount of uninsured in the state. But it has been going up, which is a big concern, but it's because of those people over 400% of poverty getting no help, and the insurance premiums going through the roof with huge high deductibles that people just cannot afford. And so this actually prevents that cost shifting and benefits every single person in the insurance market and every employer who contributes to insurance costs. That's why we did it, and it showed. We have some of the lowest premium costs in the nation. They're still startling high for anyone in Minnesota. But when you compare our rates with the rest of the nation, we're looking pretty darn good. Unfortunately, we have to bring costs under control, and we've been working on that as well. And that's what the statewide health improvement partnership and some of the other components of the Healthcare Access Fund were set up to do, was to reduce the cost of healthcare. Yes, it has grown faster than the rate of growth in other tax revenue sources, and that is by design. It is based on healthcare costs so that it grows at the rate of medical inflation. And that has meant that even so, though this bill has existed for over 25 years and has provided that if there was a shortfall in funding, that we would reduce benefits, that we would freeze enrollment, and we would drop people from enrollment, we've never had to do that because it was based on a revenue source that grows with the medical cost rate of inflation, which unfortunately is much higher than the consumer price index and what the wage increases that we see in our income tax receipts. And it has allowed, and the MA expansion actually took some people who were on Minnesota Care and put them onto full 90% federal reimbursement, which is a good thing for us, and that has allowed us to do some other things. Yes, Minnesota is unique and different, and it's because we have stepped up for our people consistently, and as a result, we have some of the lowest rates of uninsured in the nation, and I'm proud of this bill stepping up to saying that those who earn over 400% of poverty, which isn't that much money, 100% of poverty is about $10,000 a year. So it's not that much money. But this says we're going to step up to those moderate income people, and we're going to make sure that they can cover themselves, whether they happen to, and that they can fulfill their dream, whether that's working in the farm economy, working for a small employer, or starting their own small business. And those groups are disproportionately represented in the group that's this. And if you want to talk about regressivity, there is nothing more regressive that can happen in someone's life than to delay getting a cancer or other life-threatening diagnosis that could have been caught earlier if you felt like you could go in and get regular care and regular diagnostic tests. And your chances are much less. And even if you beat the odds because of modern medicine, your costs will be dramatically higher because of that. And that is the most regressive thing we can do, is not provide for all of our people the chance to catch things early, and even better yet, prevent those things from happening in the first place. And that's another thing that the Healthcare Access Fund funds.
Chair Davids.
Well, thank you, Mr. Chairman. When I look at this bill, I kind of think of on the farm, we used to say if you're losing $10 per hog, you should probably raise more hogs, because that's kind of what's going on here. We heard earlier that MNsure was just a website, just a little website that we've spent taxpayers' dollars of over $600 million on that have gone down the black hole. And as far as getting people better access with this bill, it doesn't change the deductibles. You still have a $6,500 deductible. You're still going to wait, and that cancer is going to grow because of the situation we've been put in here. Members, this bill continues the sick tax. And when I think of the sick tax, I think of back on the farm, we used to have like a Minneapolis Moline two-row corn picker, and it would get clogged up pretty easy. And so the farmer would go in, pull the corn stalks out of the corn picker, and it would recoil, even though everything was off, and his arm would go in there, and it took his arm off. We had a lot of that. So now, in my beloved Minnesota, you go to the emergency room at the mothership in Rochester, and you get your arm taken care of, well, get taken care of, $300,000, and oh, by the way, in Minnesota, we're going to tax you another X%. Now, that's just not very nice. You're sick. heart attack, it's a regressive tax on cancer treatment, heart attacks, births, accidents. And after you pay the tax on your health care, the government is going to send off some of that money directly to insurance companies. So we're sending money, writing checks to insurance companies. That's why they need more people to insure. One of the reasons, yes, some of it's for call centers. I get that. So, you know, I'm good at naming tax bills, probably the best in the history of the country. I usually don't name HHS bills, but I think we just have to name this one. I can't think of a song necessarily, but this is Omnibus Prime on steroids is what this bill is. And so I totally agree with Chair Schumacher. This bill deserves a no vote. Thank you, members.
Representative Liebling, closing comments.
Thank you very much, Mr. Chair. And first of all, I'd like to thank all of the testifiers who came up, and I want to especially thank Representative Loeffler, too. She's actually the author of the provider tax provision that is in the bill, and she gave she gave an excellent closing statement that was really kind of said a lot of what I would have wanted to say. I do just want to respond to a couple things I heard here today. And first of all, the analogy that this is like you paid off your mortgage and then you're being asked to pay more. No, 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 no. Obviously, that's a failed analogy. When you pay off your mortgage, you had a set amount of money that you were supposed to pay, and you're paying it off in installments. And when you've paid it off, you've paid it off. This is more like if I planned to quit my job and then I decided not to quit my job, would I be able to say that I'm getting a raise? No. It's just the same money that continues to come in. That is, you know, this is not a tax increase. That's just a false and misleading statement. A lot has been said here about, you know, the complaints. You know, I just would point out that the reinsurance was supposed to be a temporary solution, market stabilization, a bridge to something. But it turned out to be a bridge to nowhere because there's no solution offered. You know, obviously it's very difficult. Healthcare is obviously very complicated. But at the end of the day, you got to do something to try to help these people. And this bill, while it certainly isn't perfect, it is trying to do something. And I think you know that by the people who came up here and gave their very heartfelt testimony about why it's so important to keep the provisions in this bill, and especially to keep the provider tax in place. You know, it's so fascinating to me that this, if you want to call this bill Omnibus Prime, tell me where the road projects are. Tell me where the environmental projects are in this bill. There aren't any. This bill is about health care. This bill does so many things to improve health care for Minnesotans, to give Minnesotans the opportunity to be healthier. It's it's hard to even describe this bill because it does so many important, wonderful things for Minnesotans. And it's really going to be very difficult to do any of those things going forward if we don't maintain our very important healthcare access fund with the revenue that's come into it. Republicans have used this fund. We talked about how we're using it now for Medicaid. Some of Medicaid's spending is being financed out of that. Guess what else? Reinsurance. They took $400 million right out of the healthcare access fund for that. In the Senate bill right now, they're taking some $580 million, I think, to balance their bill right out of the healthcare access fund. So for people to then say, oh, but we don't need the fund, I think it's just smoke and mirrors. This is a very important cornerstone of what we do in Minnesota around healthcare. And as Representative Loeffler said so beautifully, what makes us a leader? I would just refer people back to the testimony also of Mary Krinke from the Hospital Association, who talked about rural hospitals. If you have a rural hospital and you care about your community's access to that hospital, you ought to be voting for this bill. Because if you don't, you are pulling the rug right out from under your hospital, as Ms. Krinke testified. And I've known Ms. Krinke for many years. I've worked with the Hospital Association. I've been on different sides of issues with them over the years. When they speak about something this way, they mean it. They are not a partisan organization. They're all about their members and the stability and ability of their members to go forward and provide care to Minnesotans. And they've been extremely clear this session that they support removing the sunset and keeping the provider tax. And as many people have said, this is the only proven court-tested, stable ability that we have to bring in this money that so many Minnesotans, I would argue every Minnesotan, depends on this fund. So with that, Mr. Chair, I thank you very much for the time, and thank you again to all of the great testifiers, and just would ask the committee to pass this bill. Thank you.
Thank you, Representative Liebling. I renew my motion to refer House File 2414 to the General Register. I'll now call for the vote. All those in favor say aye. Aye. Those opposed say nay. No. The motion does prevail. Thank you very
Mr.
much.
Chair and members.